some of our research looking into the molecular biology of NK T-cell lymphoma. So this is not going to be a very clinical talk. It's going to be slightly different from what you are used to, but I hope that at least it's a bit refreshing after a whole day of clinical data that you see some biology. So as a background, extranodal nasal type natural killer T-cell lymphoma, NKTL, is a distinct clinical pathologic entity of lymphoma that's more commonly affecting Asians and Central and South Americans compared to Caucasian population. So although it's a rare tumor, it is of particular relevance to us. And it's characterized by a clonal proliferation of NK or T cells with a cytotoxic phenotype. It's uniquely associated with EPV virus, which usually have a type 2 latency pattern with expression of LMP1 and ABNA1 with the absence of ABNA2 EPV protein. It is always detected in the neoplastic cells. In fact, in the WHO classification, is a requirement for the diagnosis of this type of NK T-cell lymphoma. Besides being more common in Asia than in Europe or the US, the other reason why it's also of particular interest
if you are talking about these small lymphocyte and lymphopratocytic cells, okay, so I'm thinking, is this IgG, another IgG myeloma with translocation 1114? So what is translocation 1114 myeloma? So in fact, it accounts for 1/5 of myeloma. Typically shows cyclin D1 overexpression and has a lymphoplasmacytic morphology. So sometimes rendering the distinction from what is from quite difficult. The typical phenotype is CD138 positive, CD19 positive, 20 positive, PAX-like positive, and cyclin D1 positive. Mostly IgG, IgA, and light chain myeloma. Okay. Although in one report it was said that 80% of IgM myeloma could be associated with this translocation. But mind you, these are by definition CD20 negative. Okay, so our previous case is really a rare exception. So how about this case? Okay, so when I look at the marrow,
imatinib present more poor prolonged effects, such as patients after transplantation having severe gut GvHD or pancytopenia, which may not tolerate quite well post-transplant TKI treatment. And then they also present their data of the post-transplantation TKI toxicity. Overall, this is tolerable. And there was only a randomized prospect study from Germany, but unfortunately, this study not compare post-transplant TKI versus no TKI. They are comparing two different strategies. One is the prophylaxis TKI, the other is preemptive TKI. Only start post-transplantation imatinib if the patient presents increased BCR-ABL transcription level. So in their group, you will see almost the same condition. In the prophylaxis group, 24 patients start imatinib, but for preemptive, only 40 patients start. There was an obvious delay in starting imatinib in the preemptive group. The follow-up the same.
First month of age to 18 months. So the later you treat, if you treat early, they're more likely to get an inhibitor than if you wait and treat them later. So the most common reason in the United States anyway is circumcision. So parents want the baby circumcised. Not every baby gets circumcised and bleeds, but if they do, then they'll get factored or exposed. We just had a new baby delivered last week that they used a vacuum extraction. It's our nice. And he had a cephalohematoma. So he had a big hematoma in his head, and he got factor for 2 days at 2 days of age. So this is a risk for him to develop inhibitor possibly later in life. But it's really not a strong, statistically significant risk factor. seems to be the highest risk is if you have to give someone a lot of factor at a young age. Basically, any child who needs surgery early on. Child has early born with a head bleed, which is possible, and you have to treat early on. A child has to have surgery or port placement early or something like that. Those high intense, tissue factor exposures to everything causing those kind of things. And then prophylaxis versus on demand, it still seems that prophylaxis has less risk of having an inhibitor than just giving therapy off and on demand therapy. So there's also an interesting thing is bleeds and being African American, actually a higher risk, at least in the United States. So how do we treat it? 1, stop bleeding. 2, get rid of inhibitor, right? So how do we get rid of the, control the bleeding? Well, if they have a low inhibitor titer, we can give 2 to 3 times more factor, which, is very, a unit of factor is $1. So what's that, 8 Hong Kong dollars for every unit. And we give, for factor 8, 50 units per kilo. So you do that, and an average size adult